Good afternoon, everyone. Today, Department of Rheumatology is presenting a very interesting patient, but the case is not as simple as the title sounds, a case of vasculitis. This was a case where the doctor and the patients, they walked together, and after 11 years, the diagnosis was regression. So for that, I'll invite Dr. Pallavi Vij, who is our senior resident in the Department of Rheumatology. She will be giving the clinical details, and Dr. Rudra Prashad Goswami, he is our faculty in the department. He'll be presenting the review of the literature. Dr. Pallavi, please.
Good afternoon, everybody. I'm Dr. Pallavi Vij, Senior Resident in the Department of Rheumatology. The case that we're presenting today in the CCR is a 30-year-old male resident of Delhi, graduate, non-smoker, non-alcoholic, vegetarian by diet, hypertensive in the past 15 years with no other known comorbidities. The patient presented to us in AIIMS in March 2021 with complaints of low to moderate grade fever, skin lesions over both his legs, and mononeuritis in the left ulnar distribution for a period of 1 month. His history dates back to the year 2000, when at 9 years of age, he was doing apparently well. When he developed complaints of fever, which was a low to moderate grade fever, intermittent in nature, not associated with any chills or rigors, with no apparent periodicity. A few months after the development of fever, the patient started noticing complaints of skin lesions over both his lower limbs. The lesions were ulcerating nodular type, erythematous, painful, non-pruritic, and healed with hyperpigmentation. A few months after the development of skin lesions, the patient started developing complaints of peripheral digital gangrene, which involved the right first, second, and the left third toe, followed by involvement of the right fourth finger. Within a few days of development of these peripheral digital gangrenes, the patient started having complaints of recurrent headache, which was a holocranial type of headache associated with nausea, severe, and was relieved intermittently only with NSAIDs. A few days after the development of this headache, the patient started developing complaints of weakness in his right foot, which was in the form of inability to dorsiflex the foot and dragging of the foot while walking. With these complaints, the patient presented to the pediatric emergency with a sudden onset weakness of the right upper and lower limb associated with the deviation of his face towards the left side, that is the 7th facial nerve palsy. There is no history of any orogenital ulcers, Raynaud's, Muller rash, GI manifestation, any proximal muscle weakness, any cuff, dyspnea, chest pain, or hemoptysis. His past history and family history was not significant. He did not give any history of a recent drug intake or a prolonged exposure to any drug. The patient was then admitted in the Department of Pediatrics with these complaints and was further investigated. As the records date back to the year 2000, patient had lost most of his medical documents, including all the reports, and the only source of information that he had were his discharge slips and the medical records from those times that he was carrying with him when he came to our OPD. Those investigations show almost unremarkable blood investigations, except a rise in ESR and CRP. All the available autoimmune profiles done at that point of time were negative, including ANA and ANCA. Further, his records show the presence of a skin biopsy report, which showed necrosis in the epidermis, distended dermal capillaries, and thrombosis in the lumen of the dermal vessels. A CT head was done at that point of time, which showed left-sided intracranial bleed. A DSL was done, which showed microaneurysms in the right hepatic and the right renal artery. Sadly, we don't have those images with us right now. So to summarize, here was a 9-year-old boy with complaints of fever, ulcerating skin nodules, peripheral digital gangrene, followed by a sudden onset right-sided hemorrhagic stroke and a right foot drop. Without any orogenital ulcers, Raynaud's, hemoptysis, no significant family history. So with these clinical details and the available investigations at that point of time, a diagnosis of classical PAN was made and patient was further treated accordingly. He received 3 pulses of IV methylprednisolone 1 gram each, followed by oral prednisolone at 1 milligram per kg per day with a slow taper. He was further immunosuppressed with oral cyclophosphamide, which he received for a period of 3 months. After institution of this therapy, the patient reported resolution of his systemic features and his skin lesions, and his motor weakness seemed to be recovering well. Further, when the steroids were tapered to less than 10 milligrams per day, the patient noticed that he had frequent skin relapses. Thus, azathioprine was added for this patient, which he received for between 2001 to 2010. Between 2010 and 12, the patient was fairly asymptomatic and was deemed to be in complete remission of his disease. And further, all the treatment was stopped at the age of 22 years in 2012. He continued to be in a period of remission for nearly 1 year when he reported back to the treating department with complaints of low to moderate grade fever, recurrent headache, new skin lesions which were similar in nature to the previous episode. Thus, the possibility of relapse was kept at this point of time and he was further investigated. The routine investigations, again, that we have are from the medical records available from that point of time, which were unremarkable. An MRI brain was repeated at that time in view of his recurrent severe headache that he was having. The MRI pictures that we have from that point of time did not show any new focal lesion in the form of any infarct or hemorrhages, only old gliotic changes, which were seen in the basal ganglia and thalamic region, and some lacunar infarcts, which again seem to be old. Thus, with this clinical history and investigation, patient was restarted on oral prednisolone, which he again received at a dose of nearly 1 milligram per kg per day with a slow taper. And he was further immunosuppressed with mycophenolate mofetil, which he received for a period of nearly 2 years. But as it was seen previously, his skin disease kept on relapsing as the steroids were tapered to less than 5 milligrams per day. At that point of time, colchicine was tried for this patient, and which he received from 2015. Eventually, in 2016, at 26 years of age, the patient attained complete remission of his disease, and it was possible to stop all the treatment for the patient, including the steroids. Around the same point of time, the patient first visited to us in the Department of Rheumatology as a routine follow-up in our transitional clinic. When the patient first visited to us in 2016, there were no apparent systemic manifestations at that point of time, and he remained under close follow-up with us between 2016 and February 21. In between that time, he had a few skin flares which were treated with short-course, low-dose corticosteroids, but he did not require any further immunosuppression during that period of time. Then again, during under our follow-up, in March 2021, the patient started developing the complaints of fever, which is again a low moderate grade fever, with recurrence of the nodular skin lesions over both the shin and features suggestive of mononeuritis in the left ulnar nerve distribution. These complaints were persistent for a period of 1 month. These are the pictures from March 2021, which shows these crops of lesions, which are both new and old, which are nodular, ulcerative in nature. And around these lesions can be seen some lacy, erythematous macules, which are suggestive of some livedoid changes. He was further investigated, and all his blood parameters were normal. Urine did not show any hematuria or any proteinuria. All the relevant autoimmune profile was done for this patient, including ANCA, ALA, NPO, PR3, which were negative. Also, an APRIL profile was done for this patient, which again was negative. It was further planned to do an NCV for this patient to confirm a diagnosis of mononeuritis, but it could not be done sadly at that point of time in view of the COVID situation. But rest of his radiological investigations, including ultrasound of the kidneys, abdomen, and chest X-ray, were normal. He was then further, at that point of time, keeping in mind a possibility of relapse of his previous diagnosis of classical PAN, we restarted the patient on oral prednisolone at 1 milligram per kg per day, followed by institution of IV cyclophosphamide pulses 3 weekly at a dose of 15 milligram per kg per dose. Following this treatment, his systemic symptoms seemed to respond well. But again, as it was previously seen in the previous episodes of flares that he has had in the past, the skin rashes reappeared as we tried to decrease the prednisolone to less than 7.5 milligrams per day. Thus, in view of his steroid dependency, recurrence of the skin lesions, we reviewed the clinical history and the medical records of the patient in light of the current flare that he was having. So here we have a 30-year-old male with the age of onset of disease at 9 years of age, with a history of hypertension, complaints of recurrent ulcerating skin nodules, a history of digital gangrene in the past, recurrent episodes of neurological deficits, including mononeuritis and hemorrhagic and ischemic stroke in the past, with systemic features. We reviewed the timeline of management for this patient and noticed that his skin lesions, the skin flares have been recurrent, requiring multiple courses of multiple prolonged treatment with oral corticosteroids. And apart from the baseline disease that he had in 2000, there were two further flares in 2015, 13, and currently in 2021, which required treatment with immunosuppressants, various immunosuppressants with multiple courses of immunosuppressants. Thus, at this point of time, our differentials were the polyarthritis nodosa, that is the diagnosis that was originally made for this patient, antiphospholipid syndrome, or could it be some other disease which can mimic PAN? His clinical picture was including hypertension, skin ulcers, nodules, gangrene. The systemic features of the disease, foot drop, and microaneurysm all supported the diagnosis of PAN for this patient. But there were certain features which were against the diagnosis of PAN, which included absence of any fibrinoid necrosis in the biopsy, presence of stroke, absence of any leukocytosis or thrombocytosis during acute phase in the past. The other differential that we had was antiphospholipid syndrome, the presence of intravascular thrombi in the dermal vessels on biopsy, history of stroke, mononeuritis multiplex, all were favoring the diagnosis of APS, but the absence of antiphospholipid antibodies in his serum made this diagnosis less likely. This made us think of the possibility of any other disease entity which might closely mimic PAN, which might be a diagnosis in this patient. So, among the diseases that can mimic PAN, the most striking to us was DARA2. The other possibilities were microscopic polyangiitis, granulomatous polyangiitis, but the absence of ANCA, absence of any upper respiratory, lower respiratory, or renal involvement was against these diseases. There is a new entity which has been recently diagnosed in 2014 called as DARA2. This is deficiency of adenosine deaminase 2 enzyme. This was the most striking diagnosis at that point of time for us in view of the long history of this patient, which was spanning nearly 2 decades, the unrelenting course of this disease, the young onset of disease, involvement of neurological system, multiple episodes of neurological involvements in this patient, and the frequency of relapses that he was having along with the therapeutic failures that we were observing. Thus, keeping that in mind, we sent a matched plasma sample of this patient along with healthy control, and a separate family member's serum was also sent. To diagnose a case of DARA2, we need a serum ADA2 levels to be less than 1 unit per liter. Surprisingly, in our case, we received the reports just 2 weeks back, and our patient's ADA2 levels were nearly undetectable. To be precise, it was 0.2 international units per liter. Thus, a final diagnosis of DARA2 was made in this patient who had been receiving treatment as a case of classical PAN for nearly 20 years now. On further reviewing the literature, we found that treatment with anti-TNF inhibitors is a good modality for these patients to induce remission in these patients. Thus, our further treatment plan is to treat the patient with TNF inhibitors, most likely infliximab. I would further like my consultant to shed light on this entity of DARA2 and provide a review of literature for this patient. Dr. Woods.
Thank you, Dr. Beach. I'm Dr. Goswami. So we encountered this disease. This is a new disease discovered back in 2014. So this group from Hong Kong, Dr. Zhao, encountered few patients of early onset atypical PAN cases clustering within a family, and they tested their samples to whole genome sequence, and they found a peculiar mutation in a gene called CCR1, which was later renamed ADA2 gene. This encodes the enzyme adenosine deaminase 2, We are all familiar with adenosine deaminase 1 gene, which deficiency of which results in severe combined immunodeficiency. However, ADA2 as an enzyme is a very poor worker on the adenosine pathway. Rather, they found that this particular product acts as a growth factor on certain myeloid lineage cells. And from 2014 onwards, the concept of a monogenic, both childhood onset and adult onset, auto-inflammatory, autoimmune disease was harvested. And after that, several reports of this disease came up from various parts of the world and even from our country. This is more common on the Western countries, Caucasians, Turkish populations, and we are not very sure how common this is in our country because of the testing barriers to testing. So this is in short, this cartoon in short depicts the pathogenesis of this disease. So ADA2, this enzyme, acts through certain unidentified receptors on monocytes, neutrophils, and endothelial cells. The major function of this enzyme is to promote differentiation of macrophages into anti-inflammatory M2 type of macrophages. It also works on monocytes and neutrophils, especially in stabilizing the neutrophil extracellular tract. And it has some role in endothelial cell integrity. Now, if we reduce this ADA2, the effects are obvious. Macrophage polarization becomes M1, inflammatory macrophages, dysregulated netosis, again resulting in dysregulated immune inflammation, and altered endothelial cell integrity, resulting in the neurologic adverse effects of this disease that we see, like intracranial bleeding, hemorrhage, etc. So, what are the points? How should we differentiate PAN from DADA2? Classical PAN is a well-described entity described over past 5 decades from this newly described disease. Certain manifestations are more common in DADA. Neurologic manifestations, which our patient has, cardiac manifestations, and GI manifestations. So visceral involvement, more visceral involvement, more neurologic involvement are in favor of this disease. Mortality is strikingly high. Relapse, however, though they say the relapse rate in PAN is higher, but this is possibly due to admixture of DADA2 cases within PAN cases because of less diagnosis of DADA2 among these. So if we go on treating these patients with classical management, relapse is going to occur. So these are the core features, earlier age of onset. So any childhood PAN should be tested for DADA. History of consanguinity within family, because the transmission is autosomal recessive type, history of consanguinity is important, and again a clustering within family. There are certain non-vasculitic manifestations which characterize this disease, which are not present in classical PAN. Lymphopenia, hypogammaglobulinemia, importantly, which was also seen in our patient, lack of thrombocytosis, lack of classical fibrillar necrosis in biopsy samples, these characterize this disease. Even neurologic features are far more common. So when should we consider that? If a PAN-like syndrome occurs in a very early age, clustered in a family, occurring with stroke, occurring with livedoacimosis, with a relapsing remitting course, with hematologic features, but for a clinician, the most important point, in a case of PAN, if you are unable to reduce the steroid dose with optimal second immunosuppression usage to below 7.5 mg per day, is taken as a marker to go ahead and test for DADA. Diagnosis is primarily made with an enzyme level and then made with a genetic diagnosis. Unfortunately, enzyme testing does not occur in India till now. We have to send the sample to outside, to Boston, and obtaining an ADA2 value to nearly 0 is required to get the diagnosis. Interestingly, there was a group from Germany. What they did is that they tested all of their vasculitis patients for DADA. And what they found is that among the classical PAN patients, quite a few patients, among 180 patients, 2 patients had values in DADA2 level, and certain patients had values of ADA2 within the carrier range. Among GP and PA patients, there were 2 patients who had values of ADA2 in the carrier range. So testing for this disease in all atypical vasculitis patients is going to become an important step in diagnosing disease. The next step of diagnosis is obviously genetic testing. Now, this is from the French vasculitis study book. They propose this algorithm. If in case you don't have genetic testing facility at our center, if we have some genetic testing facilities, then this protocol will be followed for an early diagnosis of this disease. There are some genotype to phenotype correlations which are important for a clinician. These two, that is G47R, the exon 2 mutation, and R169Q, the exon 3 mutations, are the commonest mutations available. They produce the typical diagnostic symptoms: fever, skin rash, related symptoms, hypertension, and visual vasculitis. But there are certain other mutations which occur mostly on these exon 7 and exon 9. They result in less pan-like features and more hematologic features, like hypogammaglobulinemia, cytopenias, and recurrent infections. So, like a primary immunodeficiency type of presentation can also be seen. And these are the patients which respond less to classical treatment of them. Regarding treatment, people tried with almost every available immunosuppressant agents. These agents, azathioprine, cyclosporine, colchicine, Ritux, did not work. And our patients received some of these like aza, colchicine. Some patients, some of the drugs work partially, like mycophenolate, anapin, but they were only partial. But relapse was the rule. TNF inhibitors was the only drug which showed uniformly, consistently good response. So these are the major anti-TNF trials, not trials, these are cohort studies on this disease. The most important finding of this, that majority of these patients, upon introduction of TNF inhibitors, could reduce their steroid dose, and majority could stop their steroids. And the rates of ischemic or hemorrhagic strokes reduced drastically after introduction of anti-TNF agents. So this is in short, this cartoon in short depicts how much anti-TNFs help. So if you look here in the before anti-TNF therapy, in this about 700 patient months of follow-up, there were 37 strokes. After introduction of anti-TNF therapy, no strokes in this cohort of umbrella. However, for our country, for India, we must remember the risk of TB and risk of and the need for regular screening for TB, at least at the beginning of anti-TNF therapy, because TB is endemic in our country. And if you look here in the PGI Chandigarh cohort, among 25 patients, 2 developed TB during their follow-up. So this is an important point to consider in our country. So to summarize, the other two is a newly diagnosed disease, and physicians and clinicians should be primed to this diagnosis, not only rheumatologists because of pan-like presentation, rheumatologists, and it may present to anybody, to a medicine fellow, to a rheumatologist, it may present to a cardiac vasculitis, to a cardiologist, or a GI vasculitis, to a gastroenterologist. And having a low threshold of diagnosis is the only way to diagnose. So thank you. I'll open this for any questions or discussion, if any. So if there are any questions, may I pass over to the other CCR? Oh. Sorry? Difficult to say, but PAN generally presents with hypertension due to renal artery involvement. So these patients have renal artery microaneurysms. So most likely the same pathogenesis, like PAN. These are vasculitis.
So the patient has that effect on endothelium. So endothelitis.
Yes, endothelial inflammation may be another endothelial dysfunction. And before I conclude, I must thank these guys, Dr. Arvind Chakravarty from SSK, Dr. Pui of Boston Children's Hospital, and Dr. Pui Zhao from Hong Kong Biomedical Science Center, who very kindly tested for these samples at no added cost to the patient. In histopathology, there are some studies on dermal histopathology which show lack of typical vascular features like visual necrosis and presence of dermal thrombosis in dermal vessels. And that is one feature which is characteristic of these disease. Vascular inflammation is characteristically absent. Sorry? Yes, Dr. Jha is actually doing this genetic testing, but they do samples on a batch, so we'll take another month to get it.
For hypertension and endothelial dysfunction, that is very well known etiology for hypertension, right? So these patients, they have endothelial dysfunction because of that enzyme. And those fibrin thrombi which are reported in the blood vessels, they are also because of endothelitis possibly which is happening to these patients. But typically absence of fibrinoid necrosis, which is thought to be the pathognomonic of vasculitis. That's it.
Thank you for your questions.